Good evening, ladies and gentlemen. Thank you very much for coming along to ProMed's weekly webinar series. Tonight, we're going to be looking at the time phases of major incidents. My name is Matt Dinnery. I'm the Managing Director of ProMed and your presenter this evening. Qualified teacher with PGCE. I am MIMS provider certified since 2015. Done a requal a year and a half ago. And I've done regular CPD on that earlier this year. Clinically, I'm a FREC 4. I've got a degree in biomedical sciences, and I've been working in events, looking at crowd safety, security, event safety, medical provision since 2006. And I've been producing kind of various event, crowd, medical, operational safety and plans, anything from sort of 50 right the way up to 280,000 guests. So a lot of background, certainly on the preparedness and the planning part. However, thankfully, I've never had to attend live incident, but I've obviously had to do all the planning, working with various clients, including local authorities. So they like to be, as you can imagine, incredibly robust on their plans. So just before we get started, a little bit about ProMed. Professional Medical Ambulance Services Limited is a company that's been around for 3.5 years now. We are growing. We do have more work and more inquiries coming in on an almost daily basis, and we are therefore looking to increase our pool of staff across the country. Recently had some inquiries in West Yorkshire. We've got some inquiries in Hertfordshire, Suffolk, London, and a few other areas of the UK for film and TV work. We're also looking at inquiries next year across the Northwest, East and West Midlands, Northeast, and Hertfordshire for events, as well as a few other regular ones, West Yorkshire and Northeast of England. So we do have work all across the UK, and we pay the living wage. So if you're working outside London, we pay £11.75 per hour for first responder grades, or inside of London, that's the London boroughs, is £13.50 per hour. We're proud to be a living wage employer. We took part in the Living Wage Week last week, just showcasing that if you've seen our social media. And we're a signatory to the Prompt Payment Code, which means we pay all of our suppliers, which includes our staff, within 30 days. At the moment, we're looking for first responders, so FREC 3 or higher. And we're also looking for emergency medical technicians, which according to the Purple Guide is FREC 4 or higher. If you do have higher qualifications, so FREC 5, AAP, IHCD technician, or you're a registered healthcare professional, paramedic, doctors, nurses, and you're willing to do some of the less skilled roles, I would also like to hear from you as well. And if you are interested, just drop us an email to apply@promed999.co.uk. If you're starting out on your journey and you're looking to do some additional training, or perhaps if you're a healthcare professional or FREC 4 and above and you need to do some certified annual courses to keep your life support up to date, then please do visit our website, which is promed999.co.uk/training, and that'll give you the full details of all the courses we have available and the dates. So we have the level 3 FREC for those who are needing that, and we include the administering medical gases certificate, which includes the NOx gas. That's £390. It's delivered either over 5 weekdays, or we do it over a series of 3 consecutive weekends. You'll get a copy of Ambulance Care Essentials to keep. Our next course for weekdays starts on the 13th of February. Weekends starts on the 13th of February. So that's the 13th, 14th, 20th, 21st, and the 27th of Feb. If you want to do it on weekdays, we have the 18th, 19th, 20th, 21st, and 22nd of January available at the moment as well, and that's £390. We have the level 4 first response emergency care by QualSafe, starting on the 23rd of January. That's delivered over 3 spaced out weekends, because we know that QualSafe want you to do the workbooks between the classroom delivery blocks. So it gives us a chance to review your workbooks, provide you with guidance, make sure the classroom sessions are tailored to you. We give you a copy of Ambulance Care Practice, which is the next step up, and a stethoscope to keep, so you can start using that in your practice. That's £475. If you need to requalify on immediate life support, our next course is on the 10th of January. That's just a one-day course, and we give you the latest edition of the Resource Council UK ILS guidelines, £150 for that. And our safe administration of life-saving medication courses next available on the 5th and 6th of December. That's just one weekend. And that is a two-day course, including the GR Calc pocketbook for £200, and that covers all the IM drugs and that are on Schedule 19, as well as some other common drugs that can be used. You'll need to be a employee of a CQC registered organisation to get on that course, as well as holding FRIC 4. All of our courses at the moment are running near Aylesbury, but we are also looking at a centre in West Yorkshire. But if there are 4 or more of you together that would like some training, do get in touch, as we can arrange to do those for you. So now let's get started on our training. So for those of you who are new to us, welcome for the first time. It's great to see some new faces. For those of you who've been before, welcome back. Thank you for returning. All of our training sessions, whether they are physical face-to-face or like this through Zoom or another virtual platform, we have created spaces that we believe to be free from bullying, intimidation, and harassment, because we believe that our presenters and our delegates have the right to be treated with dignity, respect, and courtesy, and not be discriminated against. Full code of conduct for this and all of our training sessions are available on the website. The link is available in the chat. And if you do need to report any inappropriate behaviour, just message the admin team during the webinar, or if you email us following the meeting, that would be absolutely fine. So there are 4 key phases of a major incident. So you've got the initial phase, the consolidation phase, the recovery phase, and the restoration of normality. So that's kind of in a bit of a nutshell. There's a little bit that happens before that, and there's a few things that kind of run through that. But in principle, there are 4 phases of a major incident. So your initial phase is that build up. So we know that an incident's been declared, and we're building up, we're ramping up what we need. We've then got the consolidation phase, where we're working at the scene and we're getting things done, and hopefully we get all of our casualties off scene. We then have the recovery phase, so we're now starting to lower the levels of response on scene. And then finally, we have the restoration of normality, where basically there is no longer any effect of that incident on our services. So that's basically it in a 2-minute little snapshot. But you're all here because you want to know about this in a lot more detail. So here is a graph that I'm sure many of you have seen a few times before. So along the x-axis at the bottom, we have the time, and the y-axis along the side, the vertical one, is the response. So response is essentially the number of resources, be they human resources or fixed assets, that we have provided to the scene. So in the initial response, let me just grab my annotating pen there. So the initial response is this part of the graph here. You can see there is quite a steep slope upwards. And that is basically because we're trying to get as many resources available at that scene as quickly as possible. So what will have happened if I just change my color? Come on, there we go. So at this point, T0, this is where the incident first took place. So this was the initiating event. You've then probably got something that's happening around about here, and this is declared. So the incident happens, things happen on scene, you get enough phone calls, you start getting some intelligence, so that is verifiable information, and you declare your incident. And then at this point, you start to then get resources arriving on scene, and that response ramps up massively. So then the next thing that's going to happen is we then have our consolidation phase. So our consolidation phase, you will notice that this line here is a straight line. So we don't add any more resources to the scene, and we don't take any resources away from the scene. It may well be that we have ambulances going between hospital and the scene, but for all, they are always considered to be part of the incident. They're not going to be redeployed elsewhere. So once we've consolidated, and that quite often can take some time, we then start to recover. So recovery is this downward slope here. Now it looks quite steep, but actually it wouldn't surprise me if recovery could look something a bit more like that. So it doesn't have to be a very steep line. It's just the downward trend. So where we no longer need as many resources to be available at scene, where most of the casualties are now off scene. We may only be treating a few left in the casualty clearing station. We might, things are still happening, but we don't need to have a massive amount of presence. And certainly for the ambulance service, that then leads to this area here, which is standby. So other agencies, the local authority, their contractors, perhaps the police, perhaps fire and rescue, are still there and they're doing their job. But actually, we only need 2 to 3 ambulances just to provide standby cover to keep everybody safe. And then the final part of that phase then, if I just find the colour of pen that we've not used yet, there aren't many of them, is restoration of normality. So restoration of normality is this area here. The line is now at the bottom. So we don't have anything at all assigned to that incident. There is no wider impact on our service. We are going about business as usual, except for one kind of really obvious and really notable thing. And that's this over here. It's our hearings, trials, inquests, public inquiry. So there's been stuff going on all throughout the incident. And although we've restored normality, although we don't have any more ambulances on standby there, although our hospitals have now got their usual routine things up and running at full speed, we may still have to release some staff to go and attend any inquests or public inquiries or other kind of hearings. So that kind of just sits kind of outside that bracket a little bit there. So before we kind of get into the initial phase, what needs to happen is we have a declaration, because actually until we've declared a major incident, we're not allocating any resources to one. We're allocating resources to an incident, and we're looking specifically here at major incidents. So we could declare major incident standby, and at that point we might actually start to be sending the resources. They might not arrive, or maybe a couple arrive and then make a declaration, but that's the first thing we can do. We can then declare the incident. So if it is absolutely obvious that's a major incident, we can declare the incident, and that is, for all emergency services, going to start a predetermined response. We're going to start to be sending quite a lot of resources in the direction of that scene. Or if we've made a standby, but actually we've got there and we've looked at it, some officers are now on scene having a look and they're going, it's a significant incident, it's a critical incident, but it's not a major incident. So I'm going to cancel the major incident. So you might see on the graph a small little rise, but then it'll drop straight back because you don't need the same levels that you need for a major incident. So moving on to the initial part of the incident, what's happening? What are we expecting to see happen in the initial part of an incident? What roles might people be undertaking? What services are we going to see? What functions are we going to be carrying out? Throw your thoughts in the chat, please. Absolutely, Mike. Heart is probably going to be sent as part of the initial response to many incidents. David, a high volume of calls is a potential early indicator, indeed, or it could just be that a bad accident has happened in a really significant place. So we do have to, really tease out that information. Neil, we want to see the roles of bronze and silver and comms officer. Chris and Henry have both said we want methane reports. Harriet and Sam said we want to see HEMS and an IRO. Dominic says we want an incident manager. Alan says we want the police there in a very large burger van. Sam wants the Silver Command away from the scene. I would disagree with that. The Silver Command needs to be on scene because the tactical level of command does require silver huddles. It requires shared understanding. It is only gold that is strategic and away from the scene. Tactics are scene tactics, not overall service tactics. MDT Mobilisation and Rendezvous from Jonathan Kahn. An independent windscreen report. Silva will be with JOC, Joint Operations Control Centre, on scene. Absolutely. If you read the ALSG, Major Incident Medical Management and Support, which is my Bible that I happen to have right here just for show and tell purposes, or if you read editions of the London Emergency Services Liaison Panel or the similar documents available in many local authority areas, you will see that they say that Silva is to be on scene. Now, I'm aware that not all ambulance services adopt that model and they prefer to keep their Silvas in their own control rooms. That rather defies the whole idea of co-location, which is a JESIP principle. If you read JESIP, JESIP will also tell you that Silva is an on-scene role. So some really good thoughts from everybody there. So the initial phase can also be called the response phase. And as a healthcare provider, we need to be implementing CSCAT. So who can tell me what CSCAT stands for? So throw them up one by one. What's our first C? I am recognizing some names from our earlier webinars, and I know we delivered CSCAT in those. So have a guess, what is the first C in CSCAT? Command, absolutely correct. So the first thing that we want to have in place is a command structure. What's the S? Safety comes next. So once we've got a command structure in place, we need to look at the safety. We need the scene to be as safe as possible because we have a legal duty for the health, safety and well-being of our employees and any third parties that may be affected by our activities. What's the next C that we put in place? Communication, comms, absolutely correct. So we now need to ensure we've got communication lines between the scene, the control room, between all of the agencies on scene, between the hospitals, including the local authority. What is the A standing for? Yep, absolutely right. Assessment. So during the initial phase, we're going to be assessing the scene. So we're going to be determining what we've got in front of us. We're going to be assessing what our needs might well be. Then let's look at the first of the T's. So what's the first T? Triage, absolutely. So initial phase, there's going to be a lot of triage going on. We need to fully understand what it is we're dealing with so that we can ensure we get the correct amount of resources to deal with that. And then the final two T's are likely to be started in the initial phase, but a lot more of it's going to be happening in the consolidation phase, and that is treatment and transportation. So we will start that in the initial phase while we're still waiting on more resources to arrive. Once we've triaged, we're not going to delay starting treatment until we've got enough resources. We're going to treat the casualties, the P1s, that need to be treated and keep them alive. And as and when we get more ambulances, we're not just going to have them sitting there waiting for the queue to form. We're going to be putting patients in them and getting them off to hospital. But actually more of that is going to take place in the next phase. It's going to be rescue. So the initial phase is mainly concerned with rescue. So every emergency service gets involved in this. We want to get casualties away from the scene. We want to keep them alive. We need to prevent the escalations of hazards. And again, when we're looking at this, we're looking at what we can do with the resources we have available. Now, majority of this is going to be the responsibility of the fire and rescue service, but that also includes the police. It also includes us. If there's anything we can do to prevent the escalation of hazards and prevent anybody else from becoming injured, then obviously that's what we need to do. There's no point in generating more casualties when we're already quite busy. We need to ensure that those in danger are evacuated. Now, it may be that they're in danger and not injured, in which case that's a police and a local authority responsible. It may be that they are in danger and inaccessible, in which case that's fire responsibility. But it may be that they're in danger but injured, in which case that is an ambulance service or a healthcare responsibility. The police are going to get themselves quite busy. They need to get some traffic management instituted as quickly as possible. because they need to be able to get the scene contained. They need to be able to clear routes for other emergency responders to be able to get to and from the scene. And the police are also going to be starting to look at maintaining the public order. So they'll want to try and get the public out the way of the emergency scene. And that just allows everybody to work a lot easier. Alan, you're right. Scene management is the overall goal in the initial phase. Specific areas for specific roles and tasks. You're absolutely right. So as more and more people arrive, we give them roles, we give them jobs to do, and we just try and get a handle on what's happening. The initial phase is do as much as we can following the process, but all we want is to get a handle on it. And then once we've got a full handle on it and the scene's fully contained, then we move into the consolidation phase. So consolidation phase, depending on which service you work for, tends to be denoted when somebody declares a major incident stop. And what that means is you've now got enough resources on scene or assigned to the incident to be able to manage without needing anything further. So if you send an ambulance off to hospital, you still want your ambulance to return. You're not saying, you know, I never want to see anything I get rid of again. You're saying, I've got 30 ambulances allocated to this incident, of which 5 are currently parked up at hospital, 10 are currently going one way or the other. I need to keep 30 ambulances assigned to my incident. Not that I need the 15 parked here to remain parked here with their handbrakes on and keys out. It's I need the full complement of 30 to be allocated. So yes, one might go off the road and refuel, or a crew might change over, as long as you get one back. So it's just about maintaining the numbers, keeping the status quo. That's what it's about. And it's during the consolidation phase that the healthcare response will use the words casualty evacuation complete. And for the healthcare response, that tends to also demarcate the end of consolidation and the beginning of recovery as far as the scene goes. During consolidation, ourselves, the police and the local authority are going to be looking for rest centres and survivor reception centres. So we've now managed to deal with those who are injured, and the local authority's got some rest centres, survivor reception centres open. The police are funneling those without injuries towards them, and we're providing just a few people just to loiter and be vigilant, because we all know that what we've termed a survivor, or somebody else has termed a survivor, might well pass out at any given moment. So we're just going to keep an eye on those. We're probably not going to get around to getting them open in the initial phases, no matter how much we might like to. They're not really top-end priority because survivors are survivors, so they don't really need our help. But in consolidation, when we've got the resources there, we do make sure that happens. There's also going to be a lot of cordoning. So we're going to have an inner cordon, we're going to have an outer cordon, and they're going to be adjusted. So longer incidents, protracted incidents, those cordons are going to move about quite a bit. Certainly the inner cordon is going to be lasting a good few days because there's going to be search for evidence, and that immediate area could be outbound for days, weeks, little area. Outer cordon. So generally speaking, the police set the outer cordon as wide as they can to give everybody as much space as possible. But once they've done that, they then tend to draw it in so that only the areas that need to be cleared are within that sort of outer cordon. So any active working areas will be within the outer cordon. Anywhere that's being declared safe is outside of the outer cordon. So the police tend to want to shrink that as much as possible, and that's as much a manpower thing as anything else, because if the outer cordon is quite large, there's going to be a lot of road intersections, there's going to be a lot of footpaths, and all of those are going to require police officers to manage them. We're going to start identifying the deceased. Police responsibility in conjunction with the health service is, we're going to confirm and certify the deceased, and then the police are going to start trying to identify them from their effects, from their appearance, and so on. Let me just have a little look. Mike Hardy, is the decision to stop across a services, or can ambulance declare stop where FRS may continue? Each service has a bronze. Which bronze? Number of bronze. Okay, so major incident stop is declared by organisation silver, who should be on scene. It cannot be declared by anybody lower than that. However, recommendations can be made by bronzes. So it is organisation silver. So it may well be that the different organizations have different priorities. So quite often the police will be one of the last ones to call stop because they're always spotting different things that they need to deal with. Fire and rescue, they will well declare that in the earlier days because fire and rescue are really good at predetermined attendance. We tend to declare it either very early or very late, and that tends to depend on everything else. Major incidents always involve the Gold Suite in control. So if you do have a major incident and it's declared, a few things are going to happen. Control is going to have its control room manager start making a few decisions. Sorry, just excuse me, I've got some sort of insect on my screen. That's better. So control room manager, they're going to be making sure that resources are dispatched as soon as they're able. They're going to be tasking a supervisor to start doing the on-call list. They're going to open the box marked major incident on their desk. They're going to grab the keys. They're going to go and get Gold Suite open. They're going to run around like a blue horse fly, making sure that all the terminals are turned on, making sure that all the phones are working, getting the big screens on the wall turned on, so that when the Gold Commanders who have just been paged start turning up at the office door, that suite is ready for them just to quickly log on and start doing their job. So yes, Gold Suite is opened very, very rapidly once an incident has been declared. In the consolidation phase, we're also going to be doing media liaison. So in the initial phase, our media liaison tends to be F off, go and wait over there outside the cordon. Once we get to consolidation and we have enough people, usually police and senior service officers available, then we'll set up a proper media reception point. We'll give them a platform, we'll whack all the cameras on, that lets them see a little bit, but not all that much. We'll create a nice little interview area. We'll throw up some roller banners and some screens and whatnot, and we'll start briefing them. But again, that's consolidation because we need, it's a low-end priority really, but we do need to keep the media happy. We do need to feed them information, so that happens during consolidation. So now we know what's happening in the easy bits. Who would like to have a guess and tell me what they think happens in recovery? So what is the recovery phase and how is recovery different to restoration of normality? Throw your thoughts in the chat, please. So Harriet says we're going to be handing the care of patients to other facilities. Chris says we're going to hand over to local authorities. Neil says we're going to start releasing units. Michael's telling us that we're going to preserve the crime scene, start the investigation as far as the police are concerned. David says the incident's still ongoing, but the aim of restoration is to start winding down the resources on scene. Absolutely, everybody is correct there. So, many different types of major incidents. And the man-made, simple, compensated incidents have the shortest recovery times. So, man-made versus natural. Man-made incidents, typically transportation, buildings, terrorism. Very defined, very clear borders, usually only affecting one or two small things. Natural tends to be over a much wider area, tends to be many more different things affected. Simple and complex. So you got simple incidents, which are just one event, whereas complex incidents affect infrastructure, affect transportation. And then you got your compensated incidents, so where the live load of casualties can be compensated just by throwing additional resources at it. Your uncompensated incidents, doesn't matter how many resources you throw at it, you've still got more casualties than your surge capacity has. So if it's a natural, complex, uncompensated incident, your recovery time is going to last for a very, very long time. But the incidents that we're used to seeing in the UK do tend to fit the definition of man-made, simple, and compensated. So during recovery, we've got additional strain on hospitals. So the routine operating lists are still going to be not necessarily suspended, but they're going to be kind of brought back slowly because the patients that have arisen from the incident are going to have ongoing needs. So they're still going to need time in the operating theatres. They're going to need time with physiotherapists. They're going to be taking up beds on the ward, and so on. Our resources on scene, we're going to start winding them down. We're going to try and get them to a level where most of our resources are doing their business as usual. But during recovery, we're still going to be maintaining some kind of presence at the scene for whatever the purpose is. Our human resources need to recover as well. So this is our staff. We need to be mindful that, you know, they've gone through a very acute, stressful environment. So they will have some kind of stress response to that. And that could lead to PTSD. So it's really important that we ensure that staff are debriefed during the recovery phase of the incident. That may include some kind of formal trim process, or it may be another internal process that we have in place, just to ensure that our human resources are being looked after and that we allow ourselves to recover as people, and we don't just think about the recovery in terms of physical. Our mental health is also very, very important. And then the occupiers. So wherever the incident happened, will be occupied by people. There'll be landowners, there'll be people who live there, there'll be people who run businesses there, and they need to be involved in the recovery effort because, you know, this incident will have caused some kind of damage. So initially it would be unsafe to enter, and those occupiers wouldn't have been given access by the police to their property. If the buildings are now in a dangerous state, then the local authority is going to exercise some powers to rectify those imminent dangers causing a hazard. And then the police, as they start to reduce the cordons, change the cordons, they are going to be trying to consult with the occupiers and give them notice so that they know when they're going to have access to their premises. They're also going to be telling them when their premises are going to fall outside the cordon, i.e. the responsibility for overall kind of security on it is going to transfer from the police back to the occupier. Local authorities, of course, can engage their approved contractors to do stuff like boarding up and repair work if things are dangerous or insecure. So next part is the restoration of normality. So let's have a think. Who's going to be leading the restoration of normality? And what are the key things that need to happen during the restoration, please? Throw your ideas in the chat. So Michael started us off by saying your fire are going to be involved looking at structural safety. Alan says the local authority are going to be much more in control providing refuges. Harriet says you're making the ready vehicles to get them back online. Nikolai is saying lots of entities can take part. David's saying that a local authority are going to lead. There's going to be repairs, making safe, and services which are going to be interrupted need to start returning to normal provision. Colin says the police will be the last people in control of the scene. Alan's telling us your restoration of power and services. So we're thinking about the utilities and our category 2 responders. Chris says take a deep breath and going. Phew, absolutely. Community organisations could support return back to normality from Dominic. Nikolai says the army, the city council, the fire department, all very good, very valid responses. So in the UK, the restoration of normality is normally a locally, sorry, I'm just going to rephrase all that. In the UK, the restoration of normality is local authority led. And that's for many different reasons. But one of the reasons is that they have specialist skills and resources. So they've got technical and engineering services. They've got skilled professionals who can advise on the status of buildings, who can advise on the status of the highways. They've got people who can look at the utilities, work with utility providers. They've also got people involved in public environmental health, so making sure that there's no outbreaks caused by any disease, any lack of cleaning. Going to be looking at sanitation, making sure all of those things are in place. It may well be that significant numbers of people have been displaced. So if we take Grenfell for an example, we're looking at hundreds of people displaced from their homes. So local authority will be looking to rehouse them, at least on a temporary basis, and provide the accommodation that they need to feel safe and secure while they get their lives back together. Local authority are who provide social services. So we're going to be looking after children, we're going to be looking after adults, going to be safeguarding. We're going to be making sure that everybody has access to the services they need just to get by on a day-to-day kind of basis. There's also going to be welfare and financial support, hopefully available, because there's been a lot of impact, a lot of disruption to people's lives. They may end up losing their jobs if businesses are closed because they've been involved in the incident. They may not be able to go to work because of the injuries that they've sustained. So the local authority will be using its kind of financial packages and benefits and referring to government agencies in that regard. And this could be quite prolonged, it could be quite extensive. So certainly Grenfell, that happened in 2017. We're now in late 2020, so 3.5 years there. That's still ongoing. Manchester Arena, local authority were probably involved in that for about 9 to 12 months in part of that process. And there's a wide range of skills and resources, and they come from the day-to-day operations. And it's important that a local authority does actually continue its business as usual in every phase of the incident. So the local authority's got a lot of different things that needs to be getting on with. It's going to make sure it continues to do all them, as well as then provide this support, because it can't neglect its residents in its other parts of its borough or its city area just because an incident's happened in one area. So there's a lot of different things happening. Alan's just pointed out that, it's a sea yellow jackets, yeah, your bin men, your street cleaners, the resilience team, front and back office, helping with patient care, door control. Chris, you're right, quite a lot of voluntary organisations can get involved with the welfare and the counselling. Because, yeah, I mean, after an incident, the street's got to be cleaned up, the refuse has got to be disappeared. We're not just going to allow Joe Public to walk down the street before we've got rid of the half-demolished building. Welfare vans are available from several of the charities. Absolutely right. I did spot a little one earlier on. I'm just going to go back to that question just to make sure I answer it. David was just asking, he said that silver commanders from all agencies will hopefully communicate directly in the Joint Operations Control Centre. What is the communication protocol for gold commanders from different agencies, given that they're likely to be geographically spread? So there's two things. Firstly, many police services have a gold cell that has terminals in for every organisation's gold commander, which connect back to their home networks. So Manchester GMP has a gold suite within the Force Command module, where the police officer, fire officer, ambulance officer at gold level will co-locate. The local authority for the area concerned will come along. Everybody turns up there and they run gold from a single room. In London, New Scotland Yard, there is an entire floor available in New Scotland Yard for this purpose. So quite often we do co-locate the golds, but in the absence of that, there is quite often video conferencing. You have your gold interagency talk group for each area available on airwave. There is also the good old-fashioned dog and bone, and that happens quite often. Yep, the Sally Army Teapot, the St John Teapot 1, Teapot 2, the Women's Institute. Absolutely, lots of people have different welfare vehicles. Your water authorities, quite often, they can provide water tankers to ensure that there is a supply of potable water in areas. And all of these things are happening because we want to get back to normal as far as people are concerned. It might not be back to normal as far as, the professionals are concerned. You know, the members of the public don't necessarily know that the power in their house is being supplied by a giant generator at the substation. They don't necessarily know that there's half a dozen tankers lined up connected to the mains water supply, keeping it topped up. But it is getting as close to normal as possible, whilst those services are then still being repaired. And as I said, parallel to that, we've got the investigations. So these could be things like hearings, there could be trials, there could be inquests, there could be public inquiries. So we're looking for what caused the incident, trying to understand how it came about. We're looking for safety lessons learned. So yes, this happened, be it by accident or deliberate, but you know, what could have been done differently that would have improved the outcome? What could the business owner have done? What could the emergency services have done? What could the local authority have done? We're looking here at kind of that safety learning. So what can we do better in our response? As Nikolai's exactly said, what can we do better to prevent these incidents happening in the first place, or where they do happen, to mitigate their effects? You know, if we can mitigate the effects before we need to improve the response, that's going to make our response significantly easier. So it's fair to say the vast majority of major incidents in the UK have been the subject of some kind of investigation. Quite often, Her Majesty's Coroner has requested that. They need to be able to record the cause of death. But there can also be public inquiries, and there can also be civil and criminal court proceedings. So the police tend to focus as quickly as possible on getting the best quality of evidence. That tends to start from the consolidation phase and then runs through every phase thereafter. So they're going to be trying to get the scene secured as soon as possible, and anything that they reasonably think might become evidence, they're going to try and preserve and not damage, move, or dispose of without speaking to their lead investigator. Obviously, our role is a little bit of a conflict with that. We like to drag bodies around. We like to get personal effects to identify people. Generally speaking, the police just want a quick photograph at the very least. Obviously, we're not stealing possessions. They're not disappearing. They just kind of want those original photographs of what was where in that immediate aftermath. So that is, in a nutshell, the 4 time phases of major incidents. So we've looked at the initial phase, the consolidation phase, the recovery phase, and then the restoration of normality. We've looked at what the different services are going to be doing in all of those phases, what kind of things you would expect to see, how people communicate, and what you need to know. So thank you very much for 45 minutes of your Thursday night. If you would like a CPD certificate for attending as a proof of attendance, then you can just email webinars at promed999.co.uk with the full name that you wish to have on the certificate. We do keep an electronic register of those who signed into Zoom, so we are going to verify that you were in this session. So if you do email us from a different email address, or your name appears differently to what's on your certificate, please just let us know in the email. We are going to verify if you've left us a review, so we'll come on to that in a second. But once you've left us a review and sent us an email, we will email you a digital certificate within 3 business days. So thank you very much for coming along. Tonight's webinar, as ever, is free of charge. So we do ask if you could leave us 1 review. Then if you've left us a review on 1 or 2 sites, please pick a review on a site that you've not yet done. We are on Trustpilot, we're on Yelp, we're on Google, and we're on Facebook. And I'm absolutely certain the admin team is in the middle of prompting you with the links in the chat. And now it's over to you. So we're going to do question and answers. I can see one coming up from Michael Carter there. So let's get stuck straight in. Michael says, what roughly is the expected time frame for each stage? It will change depending on the incident, but after confirmation of major incidents within minutes, what's the others expected to be? So first of all, the initial phase of an incident, we are looking at being between 20 and 120 minutes. So 20 minutes up to 2 hours, because depending on what specialist resources we need, we may take a little while longer. Next phase is the consolidation phase. So that for us varies quite a lot on the number of casualties. It could again take anything from 1 to 2 hours, could be 24 to say 36 hours, because on the outside of that, it may well be a little bit longer. You're absolutely right, that yellow link is a little bit short. Admin team, can you just send the full one, please? Recovery phase for us tends to be a matter of hours. But the restoration of normality in healthcare overall can last for months. There we go, there's the correct yellow link. It's just in GM or bronzes have a wider remit, perhaps. So not massively. Our bronzes are a lot more vocal. Our bronzes are used fully as bronzes, and they are asked for their views. They are asked for their opinions by silver. But generally speaking, silver are the ones who make the ultimate decisions. So does anybody else have any questions? You can raise your hand. We'll ask you to unmute yourself and we can have a two-way dialogue, or you can just ask your question verbally in the chat. David, is there any provision for private medical security welfare organisations to declare a major incident, or can it only be done by NHS staff or contractors working on 999 response contracts? I'm thinking specifically at events. David, a medical provider at an event can declare a major incident and should declare a major incident if they feel one is happening. Security, again, security control should be declaring major incidents if one is happening. Welfare organisations significantly less so. I wouldn't necessarily say they can't, but anybody can declare a major incident if they believe the definition of a major incident has been met. Within healthcare, the definition of a major incident is where the live load of casualties exceeds the immediately available number of responders available to treat them. Yep, you can use the Jessup app. So if you've not downloaded the Jessup app, go on Play Store, go on App Store, type in Jessup, download the Jessup app. It gives you methane, it gives you the step-by-step. Chris, you've declared an MI twice. I've never declared one in real life. I have done countless tabletop exercises where I've had to declare them because that's part of my remit as the medical coordinator or the medical controller. So if you do proper tabletop exercises, you will get to practice doing that. It's always good fun when you then get told, yes, that's understood. Be aware that it is 20 minutes for a heart response. Be aware that it's going to be 30 minutes before we have 12 ambulances to you. Lovely, thanks. We'll run the show then. But at least we've tabletopped it. At least we've kind of foreseen that possibility and we know exactly what's going to be happening. Does anybody else have any further questions? Please feel free to throw them in or raise your hand and we'll ask you to unmute. Chris, looks like you've got a lot of experience there. Yep, internal major incidents in the Red Cross or in Citron Ambulance or in any organisations may have their own internal major incident definitions. Absolutely. Any more questions from anybody, please? Thanks for that review, Chris. Yeah, we've got 25 people still here for the question and answer session, and it looks like we've only had a couple of people asking us questions, so please do ask away if you have any questions. This is the time when you learn the best, when you ask what's on your mind. Mike, you're very welcome. Please, you found it informative. No such thing as a stupid question. I can guarantee you that if you're thinking of it, it's very likely somebody else is as well. Chris, no problem. Admin team will get on to those certificates over the weekend, I'm sure. Neil is always keen to know what's next. Sam's also looking forward to it. So if you just give me a quick second just to bring up our menu. So next week, I'm going to be delivering on safety considerations for medical providers at events and incidents. So we're going to be looking at the health and safety legislation, the things we need to be doing to keeping our workers safe and how we go about that as event medical providers. The 3rd of December, we're going to be looking at safeguarding, that's safeguarding of vulnerable adults and the safeguarding of children. On the 10th of December, we're going to be looking at welfare services, primarily at events. how we interact with them, what their roles and remits are, how they contrast with ours, how we can support them and how they can support us. Chris, yeah, absolutely fine. That sounds great. You're away on a course next week. That's not a problem. Do jump onto our YouTube channel afterwards and make sure you can catch up. We wouldn't want you to miss out. Alex, bit tired from work. Yeah, no problem. That's fine. Please do enjoy the presentation. Nikolai, thank you for coming as well. You're very welcome. Admin team, yep, as you said, follow us on Facebook. All the webinars are advertised on there. 17th of December will be the last webinar of 2020. We are open to suggestions. So as our Christmas gift to all of you regular attendees, that is a free choice. It's open house at the moment. So the most popular suggestions, we will deliver a webinar on that as a Christmas gift from ProMed to all of our webinars. Alan, STC, at the moment, the team behind STC are incredibly busy. Winter pressures is stacking up on the NHS, so they're very busy with their day jobs. One of them is also at university, and they are, as you can imagine, got lots of placement hours to log, lots of assignments to do, lots of studying hard, which is going on. Their webinars will be restarting in the near future. We do talk to them every week. There will be some more clinical webinars coming up in the very near future on Monday evenings at 7. As you're here, you will be on our webinar mailing list. When SDC restart the clinical webinars, we will absolutely let you know. They are very, very good friends of ours. Jonathan, you're very welcome. Please do enjoy tonight. Dominic, glad that the information was useful. Chris, what are we talking about? Oh, right, you want a webinar on cardiac arrest. Actually, that's not a bad shout. The NTS, the non-technical skills around a cardiac arrest, the roles of team members, the roles of team leaders, scribes. Yes, I could actually do a very operational webinar on a cardiac arrest. It's a very good suggestion. If anybody else would be interested in cardiac arrest, do let us know. 360 degrees of management. Yep, Circle of Life, donning and doffing level 3 PPE. That can easily take an hour. Absolutely right there. How do I do that one? I may have to consider getting my really nice snazzy camera hooked up to the laptop if I'm going to do a donning and doffing. I'd also probably need some models to help me with that one. So if you know any kind of nice looking people who would be on models for donning and doffing PPE, I like the idea of that. Strokes. So strokes is a clinical thing. There's no real operational management of a stroke. So clinical matters will be STC. We can certainly pass that suggestion on to Ines and Charlotte and see if either of them would plan a clinical session on strokes. I'm sure they would be happy to do that. Tracy, thank you very much for coming. Pleased you've had a good night. There we go. It's just been confirmed. The 17th of December is the operational side of a cardiac arrest, and it looks like my admin team are planning on being willing models because they're scheduling the level 3 PPE donning and doffing session. So I hope those two are planning a night in Manchester when there can be some models. Chris, you are very welcome. So Cheryl, again, very welcome. Pleased you found it informative. So just to remind you all, if you would like a CPD certificate for attending tonight, just drop us an email to webinars@promed999.co.uk with the full name that you wish to appear on your certificate. If that email address or your name is different to how you've appeared in Zoom, please include that information because we do verify Zoom's registration process to see who was in the session tonight. We'll also check on our review sites that you've left us at least one review recently. If you have left us a review on one site previously, please pick a different site, and we will try and get a digital certificate off to you within the next 3 business days. Chris, do enjoy your studying this evening. So our reviews, as a thank you, they don't have to be 5-star, they just have to be honest, and if they're not 5 stars, we do ask that you give us constructive criticism so we know how to improve and make this even better for you. So please review us on either Trustpilot, Yelp, Google, or Facebook. Can I just say anything else in the chat? No, I can't. And we're back to the beginning. So it is now 1957. There are a few links in the chat. You may want to do a little bit of networking. I'm going to shut this down at 8 p.m. So click on any links you want to click on now. And at 8 p.m. we'll be saying goodbye. Thank you very much for attending, everybody. Have a very safe evening. Bye-bye.